Olivia, Renee, I think we are good to proceed when y'all are ready. Good morning to the commission members, at least those of you that are here. I think we
Right.
will
Go ahead and get started then.
go ahead and
Good,
get started. I know it'll take folks a minute once Olivia lets them in, so.
good thing. So good morning, everyone, and welcome to the October meeting of the Comprehensive Health Coverage Commission. I'm Renee Steele, the commission's consultant, and I'm honored to kick off today's meeting. We have a full agenda and a distinguished group of members joining us today. To start, I'll take the official roll call of the commission members. As I call your name, please unmute and confirm your presence. Lisa Carnot.
Here, good morning.
Good morning. Pam Clayton. Christy Klein Davis.
Here, good morning.
Good morning. Delvecchio Finley.
And he did send me a note. He may be late, but we may see him in a bit.
Okay. Dr. Harry Hyman.
Yes, good morning.
Good morning. Dr. Sid Moore.
He also sent me a note. He is traveling, is going to try to join us, but may have some connection issues. So just keep an eye out for him.
Will do. Dr. John Odom. Joseph Ross.
Here?
Good morning. And Kaylee Noggle.
Morning.
Good morning. Thank you all for confirming your attendance. And let me go back. Did Christy Klein Davis?
Yep, I'm here. Good morning.
Good morning. All right. So please, guys, keep your microphones muted unless you are speaking, and use the chat feature for any questions or comments you may have during the presentation. Here's a brief overview of today's agenda. We've just completed the welcome and roll call. We'll have opening remarks by Chair Noggle, and then there'll be an overview of HR 1, the One Big Beautiful Bill Act, presented by Stuart Portman, Executive Director of Medical Assistance Plans, Georgia Department of Community Health. There'll then be a discussion on next steps for the CHCC by all members, and then closing remarks and next steps by Chair Noggle. So with that, I'll turn the meeting over to Chair Noggle for opening remarks. Thank you.
Thank you so much, Renee. Welcome to our commission members that are with us. As I mentioned, I just had a couple of folks text me right before we started that may still be able to join, but thank you all for those of you that are on. It's been a little while since we last had a conversation, and safe to say, pretty drastic shifts in both landscape, healthcare policy, and even within kind of our commission makeup. And so I just want to take a moment to recognize the fact that our partners, our main partner at EY, Drew, who had served with us, and some other folks have transitioned on, and we're glad to have Renee join us on the project. You've also noticed that Sean Walker, our trustee Steve from the Department of Community Health, that was really such a valuable asset to DCH for many, many, many years, has also left DCH to pursue other opportunities still within state government. But we are proud of her and thankful and appreciative for her work as well. And we're happy to welcome other members of the DCH team who we'll get to know in the coming weeks, Amy and others. Likewise, Stuart Portman is new in his role as Medicaid Director, not actually that new at DCH or his role, but new to the commission since the last time we've heard from the Department of Community Health. So glad to have kind of a chance to introduce everybody to the new team. Certainly, we had talked previously a little bit, and we're certainly all aware, no one is blind to the news, but the reconciliation process during last winter and through the spring certainly shifted the healthcare landscape pretty drastically in terms of Medicaid. I know that in my day job, we certainly did a lot of work to preserve access to care for Georgians, and really saw a shift of how we spent our spring and summer, and really divided effort between both policy work at the state level, but at the federal level is really where much of the work has shifted. And so as we reconsider, and I know they sent out again, with the agenda, kind of our purpose and goal is really to look at some of the opportunities around reimbursement, service delivery coordination. It's really focused at our state level policy that there is still opportunity to opine on. But our original work plan that we all reviewed that EY put together last fall really included a lot of work around a landscape analysis across the country of different waivers and Medicaid policy, as well as different reimbursement models, and doing some analysis on what might be feasible or what things would look like in Georgia. And a lot of that just isn't even feasible anymore. Like certainly the statute has changed and policy dynamics have changed, that some of those things that we would have looked at probably don't make sense. So I think today will be really helpful in having a conversation and hearing an update from both the department and Stuart, and how they are preparing for the impacts of the One Big Beautiful Bill to the department and how they're proceeding forward. And then I think the plan is really to go through each of us and give everybody a couple of minutes just to share thoughts and on what some of those other topics maybe that we identified early on when we did a survey of kind of interests, what's still out there, and where we should focus our work next, so that we can then go back to EY and have them update our project plan and see where we go and what makes sense. So with that, so we'll probably go through that in just orderly fashion after Stuart, alphabetically order, I think. But I would love to welcome Stuart Portman, Georgia's Medicaid Director. Stuart, how long are you going on 2 years now? A year and a half?
Over a year and a half.
Over a year and a half. Joins us from Deep Policy Roots on Capitol Hill, and I'll let him share a little bit of his background, but we're very grateful to him for, number one, coming to be with us in Georgia to lend his expertise to the Medicaid program, and to share some updates with us today. So Stuart, looking forward to your presentation, and we'll turn it over to you and Olivia and Renee, that will make sure that your slides are viewable for everyone.
Perfect. I will make sure that I can share. Okay. Everyone should be able to see that now. But yes, I am pleased to be with all of you. I'm Stuart Portman. I'm the Medicaid Director, the more colloquial term, to being the Executive Director of the Medical Assistance Plans Division at the Department of Community Health here in Georgia. I came from Washington, D.C., where I served as the Senior Health Policy Advisor, overseeing all Medicaid and CHIP policy development. That's legislative, that's oversight, that's whatever angle it may be, where I had that role for about 7 years on the Committee of Jurisdiction that oversees Medicare and Medicaid. So it was a great honor to have that role, and a great honor to come to the state of Georgia and now really sink my teeth into the world of real Medicaid policy operations, and appreciate the chance to speak specifically to H.R. 1, commonly referred to as the One Big Beautiful Bill Act, and speak specifically to the Georgia Medicaid impacts. At this stage, most folks are aware that this bill passed on July 4th of this year, 2025. And as everyone has been reviewing what the impacts might be and the fervor that led up to that passage, the policy discussions, particularly in the winter and spring, where things landed affects every state differently. And I think that is a key component that I will speak to a little bit here. We are uniquely situated in Georgia. So as always, a good reminder that for the Department of Community Health, our purpose is shaping the future of a healthy Georgia by improving access and ensuring quality to strengthen the communities we serve. And that is front and center in all of the work that we do. So the reason I say Georgia is uniquely situated is because we are a non-expansion state that is the only state with a currently approved community engagement program. And as states are grappling with the various systems changes, policy changes, population changes, and obviously financing discussions that might follow through all of that, there are certain components, particularly community engagement, that states are trying to grapple with pretty mightily, given the timelines are quick. But we are different. because we already have the Pathways to Coverage program. And that component of qualifying activities is sort of a baseline. It's not an exact replica of what's in HR1, but it is a baseline that allows us to have a starting point that is pretty far down the field. Before getting into that, I wanted to share some of the major provisions for us in Georgia. First and foremost is that there is a provider tax moratorium that goes into effect that, because again, in the CMS and how CMS has dictated the interpretations of the statute, we are at a point where we have a moratorium on our provider taxes at the levels that they are at now. There are specific dates in statute, but the specific dates are unlikely to reflect any sort of big policy changes. At this stage, it is where they are today. And that is significant because it will affect, particularly provider taxes. We talk about that. It applies here to hospitals and providers, not physicians, not nursing homes. Nursing facilities are exempt from this sort of potential reduction in language that could apply to expansion states. But for non-expansion states, all provider taxes are held stable where they are today. That can affect future decision-making, but it is not a reduction. Expansion states are reduced slowly starting in a few years, and it drops from the 6% hold harmless threshold, which is sort of the amount that can be considered as part of a provider assessment. It drops from that 6% level to a 3.5% level over time. And so that is a real change in state financing decision-making. Similarly, state-directed payments. Those state-directed payment programs for hospitals are capped for new programs. For any program in the future that is developed, they're capped at 110% of the Medicare fee schedule. That rate is a new cap. However, there is grandfathering language for state-directed payments that already exists today, and any that were submitted earlier this year with a completed preprint by the date of enactment that would be allowed to be created at a higher level than 110%. And starting in federal fiscal year 2028, they would be decreased by 10% each year until the total amount from a percentage of Medicare is equal to 110% of Medicare. That is the most simplified version to describe something that is incredibly complicated, especially because most of these payments are not built on a scale in relation to Medicare. Many of them are connected to other payment rates. And so having to create a sense of how they fit into that national comparison is complicated. The effective date, though, is in 2028. Georgia has a number of state-directed payments. Should this policy move forward, we would be affected. The specifics of how we would be affected will only be known once CMS puts out some formal guidance to describe the process in more detail. And so we await that information, which we envision after CMS completes its review of all of the pending state-directed payment submissions from this past year and the year prior. So at some point, we will get more guidance. It will help us understand what the impact of this is. And ultimately, come 2028, if there are no statutory changes, this will go into effect and we will have to engage about what the impacts of that might be across the state. Additionally, there's the community engagement requirements. Before diving into the specifics of HR1, it's worth noting that the Pathways to Coverage program was extended through December 31st of 2026. This approval came in September of this year from CMS. The expectation is that we could have the extension with the additional policy changes that we put forward, that the governor believed very seriously in, and that we could advance for the sake of the health of the community. But come January 1st, 2027, Georgia would also be subject to the requirements of HR1. So while we have a waiver that can continue, it was not going to be a traditional renewal of a waiver. It was an extension of our existing waiver, amended to reflect the policy changes that the state viewed as important. And then we will have to work to come into compliance in less than 15 months. Those components that we will have to meet are varied. There are some systems changes. Most of those go along with the populations that are exempt. We, again, as a state, now have a policy for those that are considered eligible for being parents or legal guardians for children up to age 6. The new language in HR 1 would allow for a similar provision up to age or through age 13. For a lot of states, that's going to be a heavier lift. We already have the systems work to be compliant up to age 6. So there are changes, but it is, again, lesser than it would be for other states. However, there's still work that has to be done there, along with a number of other exemptions or populations specifically that we need to engage with. And there's some other specific statutory requirements that we may have to comply with as it relates to community engagement, but none of them will change the fundamental nature of what we do. And then importantly, and from a timeliness perspective, the Rural Health Transformation Program, it was also included in HR 1. This is a new program. It's a $50 billion fund written into the statute that would allow for states to apply for and receive apply for by November 5th of this year and receive by the end of this year a CMS approval for a full funding allocation to meet the requirements of the fund and transform rural health in the state. It is a very large effort. The department and really healthcare entities across the state are knee deep in this now, as we and our sister agencies work to develop policies that can really be transformative and bold and move the needle in rural health. We look forward to a future conversation about all that is entailed in that application, and ideally the fully funded or even overfunded proposal that we can scale to make as broad of an impact as possible here in the state. It is a few important components. One is that it's all new federal funds. There is no match required. It is intended to improve rural care and improve the ability for rural providers to have a stable work environment and a business case to continue their work. It is that $50 billion fund is divided into $10 billion per year over 5 years, with $5 billion per year evenly distributed to all states that apply. If all states apply, that equates to $100 million a year for 5 years. And then $5 billion are based on a methodology determined by the secretary. That methodology is very detailed, included in the grant application. And we have been working tirelessly to make sure that we can bring to Georgia as many of those funds as possible to work towards this transformation of care. As a result of HR 1, I just wanted to say broadly a few of the systems updates. The Gateway system, our eligibility system, will have a few things that have to change. The language explicitly within HR 1 changes the definition of a qualified alien. The lawfully present resident definition is changed, so we will have to make that change as it relates directly to eligibility. There's also a shift in retroactive eligibility. Currently, the statutory allowance is for 3 months of retroactive eligibility, and that is changed to 2 months for non-expansion states. And so that is a systems change of when someone is eligible and when payments can flow. There's also a change that is unlikely to affect Georgia, but is still something that has to be put into our system, which is related to home equity limits as it relates to assets for certain eligibility categories. And there is a new upper limit added of $1 million for home equity. And then, of course, as mentioned, the community engagement policies have multiple policies included and multiple changes as it relates to our integrated eligibility system for the state. GAMIS is our sort of master statistical information system for Medicaid. It is our source of truth for Medicaid data. We also will have to make sure that it reflects those qualified alien eligibility language changes, the retroactive eligibility shift, and the community engagement policies. Right, you have to make sure that whatever is affected on the from the member incoming and what they're seeing in terms of their eligibility portal is reflected on the back end as well. And as those are different systems, we have to make sure that they are both saying the same thing. So that will involve some funding to make sure that we can accomplish those goals. HR1 includes a small amount of funding for states to assist with that, but we will have to make sure that we move these things forward as well. And then broadly, there's other specific sections of HR1 related to the compliance and oversight function of Medicaid agencies, auditing Medicaid provider and member status. That can be related to whether or not there are providers enrolled across states or members are enrolled across states. And while there are systems to deal with that today, this sort of tightens some of that up. It also includes language relating to make sure that any member or provider who has died is also removed rapidly from any Medicaid list, as well as making sure that addresses are updated to those earlier points of cross-state interactions. So those are sort of systems update specific. Feel like it's good for everyone just to be aware. There's lots of conversations as it relates to coverage, and there's lots of conversations about benefits, but ultimately there's also a system side to this to make sure that all those discussions can actually move forward. And then specifically on enrollment, this based on the current review, and again, there will be future rulemaking formally on community engagement and guidance on a number of these provisions, but based on our current review in Georgia, we are, again, differently situated. There's a limited impact on enrollment. All of these provisions are unlikely to cause any broad categories of individuals to lose Medicaid coverage. The only area with an explicit change in their enrollment is refugees. The lawfully present resident language is the only piece that has a reduction in enrollment because of a change in definition. And we expect that to be just for awareness of the commission, less than 5,000 individuals will ultimately be affected based on our initial analysis. However, there are other states that will have much different enrollment conversations than ours. But because of where we stand, this is how we sort of have reviewed what enrollment will look like. There are a number of significant policy and financial shifts, as you referenced, Chair Nagel, that this could be, the landscape has changed dramatically. The reduced federal funding, both through state-directed payments and the loss of incentives, will change any future expansion conversations for states that have not chosen to do so, and even for expansion states to maintain that status. There are states that are evaluating that. There's also a change in the provider tax threshold for hospitals, and that can increase state obligations again in 2028 when all of these go into effect. And then that lower limit for state-directed payments, as mentioned. So those things in particular affect determinations of sources of funds, and those can have an impact on access conversations. We are not affected by those in the same way. And again, the bigger conversation on what could happen is still a very big if come 2028, because we do not have rulemaking or guidance to guide what that will look like for our state and what is grandfathered in. And then finally, just as a note, the payment error rate measurement, the PERM audit, there is language that changes the PERM audit that says beginning in 2029, this is a triennial cycle of states. A third of states every year are audited to make sure that their eligibility is clean, right? We don't have errors, we have clear processes, we actually are doing what we were supposed to do. Our year as a state is coming up, and we're in 26, which means we're also in year one of the new status quo come 2029, which states that the difference between a state's PERM error rate and the 3% error rate, which is the statutory level of an acceptable error, that is subtracted in its totality from the state's FMAP. It's a very, very serious shift. We had the last error discussion, PERM audit discussion in 2003. We were around 1.6%. So we were in a good place. We are tracking well for 2026, but in any given year, this can be a very serious shift. States can fluctuate dramatically between PERM audit cycles, and something we have to stay very focused on, because obviously if we are above 3% and we're talking about reductions in FMAP, that will have serious financial implications for the state as well. So it's something that our team is paying very close attention to. And I raise this because apart from being just a wonky provision that is included in this, it traditionally CMS has had the ability to offer states good faith waivers if you're making efforts to improve your payment accuracy and eligibility accuracy. They could dramatically reduce the severity of a statutory audit result and sort of some financial implication. But the language in HR 1 removes that good faith waiver from CMS. They do not have that ability anymore. So that difference for an error rate to that 3%, that is what goes into effect. So this is definitely putting states on notice to take eligibility accuracy seriously. And so I hope this is helpful. There's a lot of provisions. I didn't want to go through one by one. Many of you have spent a great deal of time coming through HR 1, probably more times than you would have wished, but wanted to provide a little bit more of the Georgia context, where we stand, what we are reviewing, and how we are spending a great deal of our time working towards compliance here, how it fits into the broader goals of the department, and then also, of course, trying to put the state in the best position possible for the Rural Health Transformation Program.
Thank you, Stuart. I think you mentioned to me that you have another engagement this morning, so can't stay with us too long. So if it's okay, we'll collect questions from commission members and get them back to you. But if you have just a minute, can you just retouch on the Rural Health Transformation Fund, the timeline a little bit, and maybe what some of the opportunities look like? Maybe, and I know you don't know yet, we haven't submitted, we don't have approvals, but maybe some of the highlights of the eligible categories or things that are permissible.
Happy to. So we received the timelines are fun. Anyone who works in the grant space can sort of raise your eyebrows at the timeline here because it has forced a speed that I think most state governments should applaud, that we were all able to actually get this done. We got the notice of finding opportunity on September 15th with the requirement that we submit by November 5th. No late applications are allowed. It is a very intensive application. And we will have conversations with CMS somewhere in November or December about their pre-award decision in case they end up giving us more or less than we anticipate, and how we can update our budget accordingly. And then we will be awarded the funds for year 1 by December 31st. So this is a rapid fire process. Thematically, there are some major areas of interest for CMS and for the state. First and foremost, I would say, is innovation. It's how do we bring innovation in care delivery to the state? And in order to be supportive of that, how are we improving our workforce? How are we adding more technology? And that is both, it can be base technology, talking about EMRs. It can also be conversation on technology related to cybersecurity. It can also be AI and tools in the AI space. But the point of this program, and CMS has validated the approach the state has taken, is that we are looking to make transformation. It is not intended to be anything that requires ongoing obligations of a state. It is intended to take innovative ideas that can be investments into our rural health landscape, and whether that is through infrastructure changes that are physical or technological, whether that is through payment model shifts, how do we make those changes stick so that we can have a much bolder future for how rural health is provided here in the state? I hope that helps broad level. But
yeah, I think it does. For our commission members, I know the One Big Beautiful Bill Act, or HR 1, I don't know what I don't know what it's supposed to be called today, but that's where we are. But if y'all have questions for how the department is preparing to implement, please just get those to me after the fact, and we'll try to get a list over to Stuart and see what they can respond to. Appreciate your work, Stuart. I know you've got to jump, but thank you so much for being with us this morning. And again, we're glad to have you in Georgia.
Thank you. I appreciate that.
Thank you. Renee, I'll turn it back to you.
All right, then. So we'll move on to the next agenda item, which is hearing from our members. And what I'd like to do is just to get your thoughts. I think we have so far, is Pam Clayton, did she join yet? Pam Clayton? And John Odom is not present yet. So we'll just go down the list and I'll call your name. We're going down alphabetical order. I believe everyone should have about 3 minutes or so to kind of provide your thoughts or anything that you'd like to discuss around next steps for the CHCC. And then we will, capture that information as well. But so I'll start with Lisa Carnot.
And let me just a little more context, Renee, and just as a reminder to our commission members, if you'll think back to last or when we first started, I don't know what year it was and what year it is currently even, but we did a survey and asked everyone kind of top 3 interests, where should we focus? And we shared those with everybody in kind of ranked order and developed our project plan based off a lot of that. And now just given this shifting landscape, if some of those things are no longer feasible or at least not at this moment in time until we have more guidance on how things are going to shake out, how would you reorder or reshift, or given what we know today and what our charge really is and what it isn't, where would you want to focus now going forward? So Lisa, I'm sorry I jumped in there, but I think you're first on the list.
Yeah, that's fine. Thank you for that clarification. I do think that a lot has shifted during the time that we've met and talked. The atmosphere certainly, and the landscape. I do appreciate Mr. Portman and how he's described the One Big Beautiful Bill Act. I think, as some of you probably know, I represent, for the most part, SNFs and assisted living facilities, and certainly there's a coverage gap that we've been trying to make sure we are very boisterous in discussing how we can fill that coverage gap between our very vulnerable patient population here in Georgia, with the elderly as well as the disabled. I don't know that the One Big Beautiful Bill Act helps us to that degree, but I know this group has been charged with doing some things to help us with that coverage gap. I think is one of my biggest concerns that we have. I would say part of what I have probably voiced and have huge opinion on is just our data. I do think, and not that I'm a statistics guru here, but I do think that we have a ton of data in Georgia specific to what changes we can make. And I'm not sure that we do enough forecasting or enough projecting. I don't know that we take the data and kind of create a pyramid out of it and kind of look to see how that data can really forecast the changes that we need. So I will probably stick with my, and again, I'm not a statistician by any means. I'm not an economist by any means, but I do think that we have tons of data that tell us a story, but yet we don't really write the story out for us in the future. And I think there's a story here to be told in the state of Georgia that we collect a lot, and it's clean data. It's clean data that goes in, but what comes out probably isn't statistically sound enough for us to determine where our next steps are. I'm a big data person, and I would love to see us take that data into 2040 if we can, and really heighten it for us.
Thank you. Thank you. All right. We'll go to the next member then on the list would be Christy Klein Davis.
Hey, everybody. Good to see you, and thank you. I know Mr. Portman's not here anymore, but appreciate his comments. So just a couple of ideas from me. I think first of all, just noting that and remembering, Lisa, playing off of your comments a little bit, that Georgia does have one of the highest uninsured rates in the country, and that as we think about even modest enrollment impacts and DPP cuts, that they could leave people with much more dire options, hospitals exposed, et cetera. So thinking about that, I don't want to underplay the impacts of some of what we could see coming up. I don't think any of us do. But thinking about the commission and areas that I think we could go, one that really comes to mind for me is in eligibility and enrollment. And I appreciate, again, Stuart talking about some of the lift that needs to happen within our systems and some of the lift that the agency is some of the work the agency is going to have to do in order to implement those changes. But we also have, members and people that are trying to use those systems to enroll. So thinking about how we make enrollment easier for people, thinking about the number of Georgians who we believe are currently qualified and aren't enrolled, and how we increase those numbers, as well as how we don't lose more people to uninsurance. So how we keep people in once they are in, and as we make those system upgrades, how do we really center the members and center the people who use insurance or need insurance in those improvements? And again, just think about how we can improve those enrollment systems. The other thing I am just a little curious about is the new CMO contracts, and how, I know there's been significant work around oversight for those, and how we make sure that members are receiving all the services that they should be receiving through those new contracts as they go into place. So just a couple areas that come to mind for me.
Thank you. Thank you so much. All right, we'll hear now from Delvecchio Finley.
Good morning, everyone, and my apologies for being a little tardy, but I too appreciated Stuart's comments, those that I was able to hear, and appreciate his work in our state. I think this may be building off of both of my colleagues, Lisa and Kirsty, but I agree as we kind of step back and look at really the magnitude of the shifting landscape through which the chassis on which I guess all of this sits. It's pretty daunting to think about, how to navigate that in a way that is in furtherance of our mission here to come up with ideas and sort of suggestions to the legislature and the state, but I guess maybe the legislature on comprehensive coverage and how to do that. It's refreshing in some respects to hear that some of these anticipated changes as it pertains to coverage is not as massive a projected impact to the state of Georgia. But I think to Christy's point, the baseline on which we start is already pretty I would say concerning in the sense of looking at the amount of fellow Georgians who lack coverage. So the extent to which we can look at not just sort of weathering, if you will, a potential adverse impact, a further adverse impact, but look through all of these lenses. And as Stuart was calling out, the rural health transformation opportunity that's come with HR1, how all of these changes could help us to creatively come up with ways to take data that looks at where disparities are greatest now, may be greater, and try to close those gaps or come up with suggestions for how to do that, recognizing that, there's no silver bullet for any of this. But I think kind of monitoring all the different changes that are happening within our state, maybe some exemplars of what other states are thinking about, as we have done in this body as well, to come up with some of those creative solutions that look at, again, coverage, but I would say ultimately access and how we are improving health writ large. So it's not just about, sick care, but keeping people well, and doing that in the least costly manner possible and most creative manner possible. That's not just government based, but involves our private sector colleagues as we think about, the loss of subsidies for exchange products and the like. So a lot to say there, but really my high point is, speaking from an operator side here, there's a lot of confusion and uncertainty now with everything that's coming in place. And as we kind of work through this and get in stark focus, I think that will be a little bit more stable of a foundation on which for this group to have impact, but certainly can do that in terms of tracking and collecting and exploring ideas in the meantime. So hope that's helpful.
Thank you. Thank you very much. Next, we'll hear from Dr. Harry Hyman. Dr. Hyman?
Renee, he's shot me a chat that he had to drop off for just a minute. I expect him to be back. So if we see him come back, we can circle back.
Okay, so thank you. So then we'll move on to Dr. Sid Moore. Dr. Moore?
Yeah, I'm trying to unmute. Sorry, I'm here.
Okay.
Can you hear me?
Yes.
I may not have a very good connection where I am. One thing I do know a little bit about is ambulatory surgery centers. I had suggested earlier, and I don't think this suggestion would be tremendously impacted by the big beautiful bill, but a way to move more cases into an ambulatory surgery center environment where the reimbursement, to ASCs for the state would be about half what it is to hospital outpatient departments for those available surgical procedures, and find a way to incentivize ASCs and physicians who operate there to take more of the Medicaid cases. Yes, hospitals, do lose money, on Medicaid. That's what a lot of this is about, finding ways to bridge that gap. And so on these surgery cases, they do in HOPDs, assumably they lose money on those as well. But it could be something that ASCs could handle, and a way to incentivize that would be to find a way to slightly increase reimbursement for ASCs to at least match what Medicare pays to incentivize these centers and their physicians that operate there. It'd be nice if the physician reimbursement at least matched Medicare as well, which might take a little extra funding from the state to do that, but it would, move cases to a lower cost environment, save hospitals money by not losing as much money on these cases. I would save the state money overall with much lower reimbursement for ASCs. So it seems to be at least an idea that theoretically would meet all the goals that we were tasked with the commission. So interesting times. So.
Thank you, Dr. Moore. Okay.
You're welcome.
Yes, we'll go ahead and move on then to Joseph Ross. Is he still on? I saw him earlier. I don't see him now. I don't see him right now. And Dr. Hyman has not rejoined? Doesn't look like it. Okay, well, if that's it, Kaylee, I will turn it back over to you.
Thank you so much, Renee. I'll add my 2 cents as well. I was just going to shoot Dr. Hyman a note to see if he is able to join back on. Sorry, folks. For me, I would echo similar other comments that I've heard from my colleagues and fellow commission members. It is a tricky time, and I'm a firm believer that there's always opportunity to move good work forward, even if it's not what we originally intended or not, the big shebang. But I've always said, don't discount the value of, a 1 inch or the yard, right? Like we have to keep moving forward and find ways to do the work. And I'm certainly committed to doing that. Again, appreciate Stuart for his work, and certainly have some empathy and sympathy for all of the work that's on the plate at the department right now, with the multiple systems that already were sort of in procurement or update status, but now also need updates to now comply with the provisions of HR 1 and the work that takes. At the same time, proud of them for pursuing additional opportunities where they can, and a new directed payment program that they submitted at the end of June would be pretty significant and allow lots of opportunity for the state to move forward some pretty significant health policies as well. But while the Medicaid landscape and even Medicare landscape kind of shakes out, I think it puts, you know, my ability to think through rational, reasonable, feasible recommendations right now a little bit kind of on shaky ground, not knowing really what the rules of the road are. But I do still think and echo some of what I've heard here today, whether or not that's leveraging, you know, opportunities to help streamline eligibility and enrollment. We know that, you know, normal take-up rate in Medicaid is, I think I've seen rates around 60 or 65%, that there are folks eligible for our existing programs. How do we make it so that they're aware and make, you know, avail themselves of those programs to get covered that already exist? Certainly data, Lisa, love that. I too am a data person and feel like probably everybody on this call as a commission member has a treasure trove of data that, you know, if we all synced it up, you know, the things that we could uncover and move forward. You know, I think one of the areas that we can continue to work on at the state level, and I've been encouraged lately about hearing more and more conversation under the Gold Dome with our policymakers and the governor's team and others, is really the need for a healthcare workforce. Not just in rural Georgia, particularly in rural Georgia, but everywhere in our metro centers as well, and how we really prepare for those clinicians and even beyond that, you know, the other service providers and even, you know, folks that know how to file an insurance claim to be able to run an office in rural Georgia for an internal medicine or primary care doctor. I just think there's a lot of work that we could probably dive in and look at. And there is a lot of work out there, but really synthesize maybe into, you know, where are the shortages in terms of workforce? Is it the med school pipeline? Certainly I've heard a lot recently about, you know, GME and residency slots. Is it just we need to keep more of those folks in Georgia? You know, what are the policy levers that do that? I think that's something that could be an area where we could have some further conversation that would improve access to care for a lot of folks, particularly in the behavioral health space. There's such a critical need for access to certainly behavioral health, crisis and urgent care, but also ongoing outpatient care. And I think a lot of that stems back to our workforce as well. So that's what I would kind of register as where I would see some work opportunity being more tangentially to this population, but appreciate everyone's comments. Renee, maybe if you want to kind of highlight for us, I have not heard back from Dr. Hyman, but really just from our original project plan, you know, maybe thoughts on, or I guess I'll share thoughts on maybe revisiting that in the context of what we heard today, the original surveys, and then maybe updating our project plan to see what a next conversation potentially could look like, and would welcome your thoughts on that as well.
Yes, I think that is definitely a good idea for us to do, Kaylee. We have a plan that has been laid out that clearly has some, you know, detail in it that I think based on the feedback that we've gotten here and the shifts in focus, that we could go in and kind of take a new look or baseline of where we need to go next. So that is something that we could do for sure.
Okay. So I think I will try to get Renee connected to, or Renee, you can reach out directly and we can try to get this same kind of couple of thoughts from both Dr. Hyman and Pam and Rusty, who weren't able to join us today, and then kind of recompile, you know, what looks like a road ahead. Any parting thoughts from commission members today? Okay.
Not really, Kaylee, but thank you.
Okay. Thank you so much, everyone, for being with us. And I or the team at DCH will be in touch soon after we get some follow-up work from EY. Appreciate you all and being with us today.
Thank you.
Thanks, everybody.
Thank you.
Thank you.